So, welcome everybody to another episode of the GMT podcast. It has been a while since we recorded an episode, but Dr. T and I are back at it, and we have a very special guest tonight with us. Is Dr. Taghechian, and she is not just a urologist, but also a urologist that specializes in reconstruction of the genital tracts, or what they call reconstructive gynecology. And she is based in Atlanta, Georgia, and she has a practice there. So welcome. We're going to call her the other Dr. T. Definitely the better looking Dr. T, that's for sure. So welcome to the podcast.
Thank you so much. It's great to be here. It's an absolute pleasure. Thank you for having me.
Yeah, listen, I think this is a great topic. I love taboo topics, even though I have zero taboos, and I think Ghana has zero taboos yet. But it is a very interesting topic because we deal with a lot of that, especially in the line of work that we do, especially with the weight loss operations, right? Besides of patients getting, what I call it, a new lease on life in regards to not just their appearance and how they feel, but also sometimes I call it the sexual appetite to a certain degree, right? Sure. But I do see them having a lot of problems with the looks or how we work with excess skin, etc. I've had some patients that have gone abroad and getting rejuvenation, as a lack of a better word, or things to enhance them, to make it feel better and so forth. So I'm trying to figure out, what do you see on that line in regards with the weight loss patients and what you're seeing now in your practice and what you do for those?
Honestly, it's not that much different, but, weight loss affects every part of your body. You know that better than I do. And let's talk about women in their vulvar area, especially the labia majora, really that's all fat. And so with weight loss, you can see a lot of loss of volume in the labia majora. And some people describe it as looking like a flat tire. It just doesn't look as plump and lively as it used to. So that changes. And frankly, that can even change with age. So it really happens to a lot of women for a lot of different reasons. But those are things that thankfully can be addressed. I don't think there's a lot of people that address that cosmetic aspect of the vulva. You really have to seek people out. I don't think you necessarily have to go overseas for that anymore. It's certainly something that I offer at my practice, but there are ways to combat that change in the external genitalia when it comes specifically to weight loss. It can also affect the labia minora, I would say, which are more the inner lips. Those can, vary by size, not just with weight loss and weight gain, but also just with gravity, getting older, having children. All of those can affect the way the labia minora look. And we do things like labiaplasties, where we can actually trim some of that excess tissue and, give the patient their confidence back in terms of the way things look. And I would say weight loss and weight gain, either way, also affect more of the inside of the vagina, not just the outside. But stress incontinence, urge incontinence, vaginal laxity, decreased sensation with intercourse, all of these can happen sort of with this wear and tear and changes of the body, whether with age or with weight loss.
Mm-hmm. So what are the changes that happen to the inner vagina as well that you kind of touched upon,
Sure. So I have women come to me complaining of what they call vaginal laxity, or they feel like things are loose. Things have changed since they were younger. They don't feel like they can grab as tight as they used to. So I see a lot of that. And like I said, with the fluctuations in weight, you can have problems with incontinence, which is usually an anatomic issue when it comes to stress incontinence. So these things can be addressed in my practice. I do offer, it's an umbrella term, but vaginal rejuvenation, let's say. But vaginal rejuvenation can mean a lot of things to different people. Things that I like to offer that I feel safe in offering are radiofrequency treatments of the vaginal wall. Radiofrequency applied to any tissue can help with tightening of the tissue, building collagen, building elastin. I use a system called Morpheus 8 of the vagina. Many in the plastics world use Morpheus everywhere else. And so thankfully there's a wand that can be used inside the vagina as well. So we do radiofrequency and microneedling of the vaginal mucosa, and that helps with tightening. So not just for sensation during intercourse, but tightening the tissue around the urethra or the tube that one pees out of, that can actually help with incontinence quite a bit. And we've also found that doing this treatment to the wall of the vagina that touches the bladder, it can actually cause or lead to some neuromodulation of the nerves that go to the bladder and can help with symptoms like overactive bladder and urge incontinence, which is that leakage with that urgency to go. So lots of fun things in the vagina that we can fix.
Now, that's pretty impressive, right? I mean, the technology has advanced so much that you're allowed to, a lot of that, what you're talking about, radiofrequency ablation, we use that for different things that we do even our own patients, right?
Absolutely.
Same thing, like if the patient has a lax pouch or a lax anastomosis or connection, you use almost the same thing to kind of tension up and create more of a restriction perspective.
Yes.
So the technology is there for sure. But besides that, do you see patients that we require or you're looking for a vaginal rejuvenation, as you said, an umbrella, but also they also need some kind of psychological perspective in terms of allowing you to realign everything, because it doesn't matter, right? If you only take care of sometimes I like to tell, the part of the body that you can use it, but you don't really taking care of the mental perspective, right?
Absolutely.
So do you do that too before you do the procedures or afterwards, or how does it work?
It's very patient specific. I tell my patients sex is complicated. Probably more so for women than for men. Like everything has to align. Mentally, you have to be there. Hormonally, you have to be there. Physically, you have to be there. And if, one of these things are missing, then you're just not going to enjoy the experience. You're not, it's just not going to be fun for you. So in my assessment of the patient, I try to figure out what is going on with this patient. Is it just purely anatomic issues that we have to deal with, or is it more involved than that? Is it, a relationship issue between them and their partner? Is there some kind of mental block happening? And, I'm used to this line of questioning. I'm very comfortable talking about sex and all this stuff. So it's not a problem for me. So I can tease it out a little bit. And if I see that, this is not just an anatomic problem that we're dealing with, then I am very, very quick to refer my patients to sex therapists. I don't have that skill set. I wish I did, but I don't. But thankfully, there's a lot of well-qualified sex therapists out there. And this is what they do. And it can be really life-changing for patients. They just have to be, open to it. And if they're open to it, then they can really get some great results.
Mm-hmm. And, kind of switching topics a little bit about that, we touched a little bit about the incontinence, and this is something that women especially are prone to have, especially if they've had multiple childbirths as they age a little bit. And we also know that the majority of our patients, and they're affected by weight issues and that tend to have bariatric surgery, tend to be women too. So can you talk to us a little bit about stress incontinence, basically. And does obesity increase your risk of having that? And can you tell us what are the different things that you can do to help counteract that?
100%. Yes, of course, your patient population is going to be at an increased risk of stress incontinence. You know, certainly the pressure on the bladder and the pelvic area will take their toll. Add childbirth to that, add gravity to that, add getting older and losing collagen to that. So yes, it is not a surprise that women have to deal with this stress incontinence. Thankfully, there are lots of awesome treatments out there, and I can go through them with you. So usually what happens, and I can't say this is 100% of the time, but let's say 95% of the time, the reason a woman ends up with stress incontinence, which is specifically leakage that occurs with coughing, sneezing, laughing, exercising. This happens because the urethra, or the tube that women urinate out of, it's not well supported like it used to be. And so when the woman coughs or sneezes, the urethra moves, and that changes the angle between the urethra and the patient's bladder. And so when it moves, it lets some urine escape through the urethra, and there you go. You got yourself some incontinence. So it's an anatomic issue. So in order to fix stress incontinence, you have to fix their anatomy. And so the things that I offer my patients, I've already mentioned the radiofrequency treatment. This is good for somebody who I would say has mild stress incontinence, not major stress incontinence, but mild stress incontinence. Certainly we can fix it with that. Pelvic floor physical therapy. So meeting with a physical therapist specifically that just deals with the pelvic floor. They're very good at helping patients retrain and strengthen their muscles in the pelvic area. Other technologies that we offer, if you want to be super conservative, I offer something called V-tone, which probably most people haven't heard of, but I describe it like an electric tampon. Goes into the vagina, sets off electrical stimulation, which ultimately causes contraction of the pelvic muscles. So it's a therapy, half-an-hour session for 6 weeks where you're just coming and doing like super therapeutic Kegels. Like you could not do Kegels this strong on your own. And by the end of that 6 weeks, you have much stronger muscles that will help you compensate when you cough or sneeze or what have you. Again, I would say that's very good for mild incontinence. Other things that I offer, not a whole lot of urologists are offering this yet. It hasn't really become very mainstream. I have been doing this for the past 3 years, and I love it. We actually have a center of excellence at my office for this, the only one in Georgia, but it's called Bulkamid. So Bulkamid is basically a filler, right? Same kind of filler you'd put in your face and what have you. But it is injected into the walls of the urethra. So you're bulking up the walls of the tube that you pee out of. So there's more resistance against leakage. So quick 15-minute procedure, just a couple of injections under local anesthesia to the urethra, no downtime, and about an 80% success rate. The idea of urethral bulking is not a new idea, but until recently, like for us, the past 3 years, the materials that we've had for urethral bulking have been horrible. They didn't work. They didn't stay in place. You had to keep getting re-injected over and over again. So we never, as urologists, really offered that as a real treatment until Bulkamid came along. So Bulkamid has been around for a long time in Europe, for the past 8 years, 9 years in Europe. In Europe, they're not allowed to use any kind of mesh material in the vagina. So there's no slings or anything like that. So it sort of came around as necessity, I would say. And so those ladies who were injected 8 years ago in Europe, they're still going strong. The gel is still holding up. So we only have 8 years of data, but who knows how long this will last. But it's a fantastic option, and it's my go-to for the last 3 years. These women are very happy. The last thing we offer is a sling, a mid-urethral sling. So a sling is a small piece of mesh that we insert under the urethra to keep it from flopping around. So it just keeps it in place. And that's how you prevent stress incontinence from happening. It is still considered to be the gold standard here in the US. But just like any surgery, there are risks. Minimal, but they're there. There's risk of, bladder injury as we're inserting the mesh, or there's risks of urinary retention, like it's working a little too well, whether it be short term or long term. It may require a second surgery to go loosen the sling. So, it's got risks, but it still works fantastically. I mean, that's all I did until 3 years ago when Bulkamid came around. So it's still on the radar for me, but I'll be honest, in the past 3 years, I haven't done one sling because I haven't had to. So it's been a game changer for me. And I'm very lucky that I have it in my arsenal to offer patients. And I hope more and more urologists get on the bandwagon for that, because many women could benefit from it.
Yeah. So, it's interesting talking about different ways to do things. And the thing you just said there before, the sling, along with a friend of mine, just have to be good enough, right? You don't have to beat the gold standard. If it's good enough and has a much lower risk profile, right? You go 100%. The best example of this is angioplasty, stents, and cardiac surgery, right? Back in the days.
Yes.
It's just good enough.
Yeah.
Right?
Yeah.
Because now they're doing, a cardiac surgery, people that have angioplasties and stents. So you still have to do it. So I agree with you on that perspective. I think it's always great when you have such a wide range of possibility of treatment from that issue. So let me ask you this. I'm going to run an example. It just happened to me. I operated on Monday on a 22-year-old female, BMI 75, right, with diapers, right, because she was having so much urinary issues, right? So a patient like that, I'm not sure that, because we never follow up in regards to that urinary retention or whatever, right? We always want to know how they're doing in terms of the nutrition perspective and the diets and the weight loss and the metabolic diseases. But we truly, be super honest, we really don't dig into that issue, right? Same thing, we really don't dig into their sexual activities or how they're doing, if they're okay. The mental component, we can see it, then we can kind of talk about it and refer to our in-house psychologist. I'm not sure that a weight alone for a patient like that, because even if she loses 150 pounds, she's still going to have a very high BMI. She has to lose about 250, right, just to get there. So I'm not sure that alone will fix the issue of her bladder issue or the urinary issue, right? So with a patient like that, how do you work them up? I mean, are we talking about a patient like this first has to do plastic surgery in regards to the excess weight for the abdomen, from the abdominoplasty, from the thighs? Then you start talking about, okay, maybe we can do a rejuvenation, like you said, some radiofrequency ablation, some fillers. See, those are the tricky patients, because day-to-day ones is easy for us to take care of it. But the tricky ones, that's we want we see it.
Yeah.
I don't know how would you tackle those?
It is difficult for sure, especially with a larger BMI. We really do try to encourage the patients to have weight loss, or maybe they need to come to you because they need extreme weight loss to be able to do a surgery like a sling. It's just not safe otherwise. And frankly, I don't know if it would hold, right? So you want to give the patient their best chance. And something like a sling, you want to do it once. You really only get one chance to do it. You're not going to go in and put another sling on top of a sling, or frankly, just doing a repeat procedure there. you're going to have more complications. So you just have to try to set them up for the best case scenario. But, you know, as a physician, I don't want to cause more problems. I want to try to fix problems. So, you know, if I can't do something, if I feel like it's not safe for the patient, I'm going to be honest with them and I'm going to tell them, you know, we can't. But if there are, you know, and that's really when it comes to sling. But there could be other things that I could do, right? That is not necessarily as risky, that could improve their quality of life. I mean, I just named a bunch of stuff. I don't see why we couldn't do something like a bulkamid. It's not going to be that much more difficult to do bulkamid or doing the V-tone, right? Really, in terms of doing something like the vaginal rejuvenation, if I've got space, if I can get my wand into the vaginal canal, I'll do it. You know, and there's minimal or really no risk to that. So it really depends, on what the patient needs. And I would say all incontinence is not the same, right? We have different kinds of incontinence. So there's stress incontinence for sure, but your patient may also have urge incontinence, which is completely different. It's a completely different animal. It has nothing to do with anatomy. It is just a misbehavior of the bladder muscle, right? And so for that, surgery is not necessarily going to fix it, right? So we have other things. It may be medication. It may be a quick Botox injection into the bladder. So it's not your job as bariatric surgeons to figure that out. But, oh my God, I think the patient would appreciate it so much if you just touched on, hey, do you have these issues? And if you do, guess what? I've got a urologist. I'll send you to them. You can talk to them about it. There are things that you can do because there are.
Excellent. Yeah.
Do you want to move to Orlando?
I love it. Thank you.
Yeah.
I think we have a lot of business for you here.
There's a lot of people suffering for sure, but there's a lot of people that we can help. I wish we could shout things from the rooftops. Honestly, people just think they're stuck, not just in your situation, in all kinds of situations. Like, oh, you know, this is par for the course. This is just the way life is. This is just what happens. And no, it's not. There are treatments for a lot of these things. You don't have to suffer.
Especially education, right? It's all about education and outreach.
It is. It's all about
right?
education.
And there's also a taboo, right? I mean, we saw recently Orlando Health put out a survey about taboos on weight loss perspective, right? And believe it or not, there was a very high number of people that thought weight loss should be the last thing they should do, right? There was a big taboo about it. And there was a very stigma to it that still nowadays is less than what it was when I went to fellowship like 13 years ago, right? But it's still, right? It's still this taboo. And then it's very interesting because the obesity in this country, it's alarming to the point that reference points have changed.
Yes.
We see people coming to office BMI 38, 39, 40, and not sure they're big enough or have enough weight to qualify for surgery. Because around them, 50, 60, 70 is normal, right?
Yes.
So it's very interesting for the perspective. And I think when we're talking about urinary, vaginal, sexual organs and so forth, it is such a huge taboo.
Sure is.
Right?
Sure
and
is.
I'm not going to get into why I think it is, because it might be very tabooish. But I come from a different country that we still have it, but to a much less degree than we have here. And I think that's what you were going against, right? Urologists in general, male, female, there's always this taboo associated with it, which shouldn't. It shouldn't at all.
But even in the urology world, even more so in terms of taboo, it's even worse for the women than it is for the men, right?
Yeah.
With men, I have ED. Give me some Viagra, give me some Cialis. All that stuff is covered by insurance. Like, it's easier to talk about these things as a man, I think it's still not easy, but it is way easier than a woman, right?
Well,
a woman,
100%.
Coming in and being like, I'm not satisfied. Things don't feel the way they used to. I just don't enjoy sex. You know, you don't hear that at all. Like,
but do you think it's because the majority of the urologists are male?
That's a huge part of it.
Yeah, exactly.
That's a huge part of it, for sure.
I think it might be multifactorial, though. Might be that the huge, the majority of the urologists are male. I think also our society in general tends to be more harsh on women talking about those things as opposed to men. We kind of start to normalizing men talking about it, but not much so women, really.
Yeah,
right?
But this is the thing. This is what gets me. Women, if they do have issues, if they bring it up, it tends to be with their gynecologist, right?
Exactly.
You think, okay, gynecologist, vagina, they can fix it.
Yeah.
But guess what? They don't. They're like, sex? I don't do that. I'm sorry. And then so they send the patient to the urologist, who's the other person that
most of
works.
The time.
Right. Or even a woman still, like, because a lot of the gynecologists are women, right? They're mostly women, I would say. But then they go to the urologist and the urologist is like, that's not what I do. I'm sorry. So who do these women end up going to? There's nobody that takes care of their sexual health. Literally, there isn't anybody that takes care of women's sexual health. There's no research that's being done. I mean, nobody cares to look into things. I mean, just something simple like vaginal estrogen. It fixes so many problems, but nobody's giving women vaginal estrogen prophylactically as they enter into perimenopause. And it does so much good for women. There is directly a line between the lack of vaginal estrogen and mortality. So losing vaginal estrogen, you have a 30% increase in overall mortality in women. Can you believe that? There's actually a straight line and nobody does anything about it. I don't know. Women are really overlooked. And I'm just one voice, but I'm seeing more and more physicians come out and advocate for women and try to get the word out there that, look, we are here to care for you. There are physicians that are willing to listen and willing to help you. They may not be everywhere, but you can seek them out. You can find them. There should be several in every state, at least. They may not be super easy to find, but they're not impossible to find either.
It sounds like the change is starting, but it's not quite there yet. Probably might be in 20 years or so. But, we kind of talked about men too. So, speaking of, can you talk, even though you specialize in reconstructive gynecology, but you're still a urologist, can you talk to us about the effects of obesity on the male? In terms of, ED or other effects as well, decreased libido, etc.
Yes, exactly. It can affect so many things. Physically, certainly, it can affect. I have some men come to me who have, gained some weight over the years, and they tell me, Doc, my penis has shrunk. I'm like, you know what? Okay. I promise you, it actually hasn't shrunk. It's still there, but it's an illusion. It's an optical illusion. Everything around it is a little bit bigger, so it's been buried.
It's all about reference point.
So, I push in on the area around the penis, and voila, it's actually still there. So, I mean, certainly it can affect things that way. I promise the penis is not disappearing. It is still there. So you don't have to worry that things are actually shrinking. I would say there's a little bit of a use it or lose it phenomenon, though. Like if you are not getting regular erections, like that nocturnal erection sort of serves a purpose, bringing that blood flow to the area, stretching out the tissue, bringing, oxygen, nutrients, what have you. That is important. So if you're not really getting that anymore for whatever reason, there can be a little bit of decrease in size, but not like inches. All right. The other thing that I do see obesity is it's going to affect your hormones 100%, right? Testosterone, estrogen, and testosterone is directly linked to libido. right? And if you have a lack of testosterone, because I think more men, as you get bigger, that testosterone starts to go down.
Yeah.
So their libido is going to decrease. They're not going to really want to engage in sexual activity. And, that might affect their relationship with their partner. But that can actually be treated. Absolutely. There's hormone replacement therapy. We just monitor the patient super closely, but they get that, zest for life again. They're not quite as tired anymore. They're more motivated. They have better sleep. Maybe that helps them go to the gym more, right? They just have a better outlook on life as we replace their testosterone. And that could probably help their weight loss journey as well. So those are the things that I see. And testosterone or lack thereof can also have an effect on one's cardiovascular health as well. So it really is important to sort of help these men along on their journey as they're getting healthier by paying attention to their hormones.
The only thing with testosterone replacement, I think once you get used to it, you really like that, and then you don't want to get out of it, right? And then you can have, I see some people having some pretty bad crashes, right? In terms of they stop taking, the insurance doesn't cover this and that. Man, they go from hyper happy to super depressed.
That is true.
Right?
That is true.
That's why I want to tell my patients that if you want to embark on that, make sure you have someone that's really managing.
Yes.
Because I don't know how's in Georgia and Atlanta specifically, but Florida, there is this thing that a lot of people find a way to get pellets implants for testosterone, progesterone, hormones, whatever, right? So they find some other places, quote unquote,
men's clinics,
clinics, right? And they get an injection, right? So, and you always see these people that super unregulated testosterone and progesterone and so forth, which is dangerous though. It's very dangerous, very dangerous.
100%. Yeah. You have to go to somebody who knows what they're doing. And I promise you, these men's clinics are not the place. They're not run by urologists or frankly, even endocrinologists. Like even that would be great, but it's run by people who are not trained. They're not educated in hormone replacement in men. And
they're not even physicians most of the time. They're not even physicians. They're not even physicians most of the time.
They're not even physicians. Yes, yes. Don't get me started. But yes, they're not even physicians. So these patients come to you with like these crazy high levels of testosterone. Like, what is happening? And listen, there are risks to high testosterone. It's not just, oh, I feel so good. You have to monitor labs, monitor different things because you can kill a person on testosterone. And these places are not monitoring them in the least. In fact, I think they push them to be super therapeutic, to feel like Superman. Like, you don't have to be Superman. You just have to be in the normal range. That's enough. But yes, you do really have to make sure you go to somebody reputable who knows what they're doing, who has your best interest in mind and not lining their pockets in mind.
100%. I agree with you.
Yes.
Perfect. So bottom line, to summarize, what you're really saying, if you're a female patient, you've had weight loss surgery, you lost quite a bit of weight, and you need some reconstructive options of your female reproductive areas, there are a lot of options that can be looked into, and seek a professional like yourself that can help. If you're also a female patient who is overweight and suffers from incontinence, or just obviously who is not overweight and suffers from incontinence, you need to obviously seek a professional. And also there's a lot of options. And nowadays it's not always as invasive as it used to be. And it sounds like weight loss can be very beneficial for you to help prevent at least one part of that incontinence, which is the stress incontinence.
Got it.
And if you're a male patient, weight loss can help a lot, basically, with getting your preventing, first of all, erectile dysfunction and getting your libido, back up. And if you need some also replacement therapy, seek a professional as well. Like,
Please.
So if someone wants to follow up with you, what's the best way to do it?
So I'm at 2 different places. I
Oh,
have my
boy.
urology practice.
One in Orlando and one in Atlanta.
I love it. Maybe one day. You never know. But for my urology practice, I'm with Georgia Urology. And Georgia Urology, I see patients in our Smyrna location and our Woodstock location. And I also have opened off this offshoot called Aayla, Sexual Wellness and Aesthetics, which is just for women's sexual wellness, because God knows we need it. And information on that could be found on aayla.com, Aayla.com.
I like it.
Yeah.
Why Aayla?
I like the name. When I was looking up names, it meant the halo around the moon, which, romantic. I love that. Why not? So
in which language is that? Which language?
Multiple languages, actually.
Oh,
but I don't
really?
know what specific one this one I was looking at, but it comes up in a couple of different languages.
That's awesome.
Nice.
Listen, this has been an amazing, super well informative. Even for myself, and I guarantee for Ghanem too. You won't say it. But it's been super well informative. And there's so many taboo topics that is so well interconnected with obesity and other things that sometimes we get so focused on treating one thing and we forget the rest of it, right?
That's right.
Thanks to you, now I'm going to pay attention a lot more closely
I love it.
to the urinary perspective. I mean, the urinary perspective, right? The sexual activities, I think, for my patients, and refer them to the right people.
Absolutely.
I don't know if you do virtual consults or not, but if they do, they probably can find that on your website. But it has been an amazing. I do thank you. Well, excuse me. We do thank you for your time that you spent with us on a Tuesday evening.
I appreciate your time as well. It's been so much fun, and thank you for letting me share what I do.
Well,
awesome.
Thank you for joining.
Thank you.
Take care.
Have a good night.
Thank you.
Thank you.